Hello and welcome to episode 230 of the Ideal Nutrition Podcast. My name is Aidan Muir and I'm here with my co-host Torwen Eerkens, and today we're going to be talking about blood tests we recommend getting. We're going to be splitting this up into three categories. We're going to be talking about nutrients. We're going to have a section on metabolic and miscellaneous, like metabolic conditions and stuff like that. And then we're going to have a section on hormones. We might touch on specific conditions within there as well. For starters, I would always get a doctor to include the things that they're naturally going to include anyway. I wouldn't just be like, only get these ones. So I'd get them to include what they're going to include. I just think that there's many situations where I'd also want them to potentially include some other things as well, if relevant too. We're going to start with that nutrient section and we'll probably go like back and forth one at a time. So do you want to go first, Torwen?
Yeah, I mean, the big one, and I think this is something that's, for most people, it's fairly important, is looking at iron. So doing the full iron studies, ferritin, serum iron, transferrin, TIBC, because we know that low ferritin is associated with fatigue, brain fog, low exercise tolerance, and all the rest.
I'm really big on that. I feel like it's hard to feel good if you have low iron, and it's a big one to address. It's also so prevalent as well, very worth doing. Another one, and I'm going to lump these two together, is vitamin B12 and also folate as well. So these are important for energy as well. That's why you can also get anemia with low B12 too. Red blood cells and neurological health. These might be more common in people who are plant-based, but then also we know with B12 as well, as people get older, their kind of absorption of B12 gets worse as well. And I've talked about this previously on the podcast, but above, say, like the age of 70, it's surprisingly prevalent how common deficiency is, or very close to deficiency is very prevalent too.
Cool. The next one I'll say is vitamin D then, which we know is important for bone health, immunity, mood regulation. And here I would definitely consider it, especially if you're a office worker, you're inside a lot, if you're a little bit older and you're not getting outside as much as you used to, winter, that sort of thing. It's so easy to supplement and it can make a really big difference.
Some things I'm less concerned about from the nutrient perspective is magnesium and calcium if you're using it to measure your intake, because they're not really reflective of that because of a thing called homeostasis, which basically means, let's use calcium as an example. If the calcium in your blood drops and it starts to go as if it was about to go out of range or too low, your body will pull calcium from the bone and put that into the blood. Obviously, you could then be on the path towards osteoporosis, but your blood levels look good. Vice versa, if it starts to get towards high and you're just getting calcium through food, in your gut, you'll stop absorbing calcium to the same degree, and it has these mechanisms to keep it within range. If that got out of range, it's less indicative of your calcium intake and more indicative of other things going on, potentially kidney issues, for example.
Cool. I'm going to add zinc to that then, because it is important for immune, wound function and hair growth and things like that. Especially if I was seeing a client who potentially had lower intake or a restrictive diet, this is definitely something that I would add in to consider then.
Something I've been talking about more recently is with zinc intake. If people are supplementing zinc, and there's many benefits that can be associated with that if somebody was to otherwise have a low zinc intake, but if somebody is supplementing, I'd be cautious of going too high. I think dosages like 50 milligrams per day are fine short term. Long term, it's potentially risky because it can lead to a copper deficiency because they're competing for absorption. So if somebody is doing a higher dose for a short term, I think it's often a good thing if it's addressing something, but I would always just be cautious of doing that year round.
Anything else that you wanted to add?
No, let's talk metabolic stuff.
Amazing. I mean, I'm going to start with the big one here, and we're going to talk about glucose. So fasting glucose and HbA1c levels, assessing that blood sugar control in someone and their insulin sensitivity to see if there is any element of type 2 diabetes, type 1 diabetes, and what impact that's having on their control of their blood sugar levels.
So HbA1c is really helpful because it is basically measuring your 3-monthly average, because it's associated with your red blood cells, which typically have a lifespan of around 3 months. So you can kind of assess if your blood glucose levels are elevated. And obviously we want to be on top of that because we could get onto potentially predicting like pre-diabetes early. And with any of this, the quicker you can address it, the better. It is obviously very much possible to reverse type 2 diabetes, even if it's quite progressed. But the earlier you get onto it, the better things are. The next one I'm going to talk about, kind of in the same vein, I guess, is cholesterol and triglycerides. These are another ones you want to be on top of as well. There's also varying ranges here. So I'm just going to talk total cholesterol for a second. I know there's a lot more nuance within this. We could do an entire episode just on this. But often there's some ranges of like 4.0 millimole per litre, 5.5 and 6, where some doctors will tell you that you're high if you hit 5.5 or above. Some will tell you that you're high if you hit 6 or above. But often there's also categories of like primary prevention, secondary prevention, where primary prevention is around like 4.0, secondary is around 6.0. And it is food for thought that like you could be at like 5.9 and there's chances that like you're not considered high and it's not a concern or anything like that. But that's also quite far from, say, the primary prevention kind of route as well. And going deep on like the longevity stuff, there is a reason why when people get put on statins, and you can have your own opinion on statins, but like there's a reason when people get put on statins that they do tank their LDL cholesterol, particularly like super, super, super low. And one of the biggest things is it just reduces the risk of cardiovascular disease. So like whether you have your own opinion on that, one thing is that it is a good idea to try to keep this like on the lower side if possible.
Next one that I'll talk about then are liver function tests. So ALT, AST, GGT. We talk about ALP and bilirubin sometimes as well, to detect if there is any inflammation or potential fatty liver that's going on. So to help guide whether or not we need to support weight loss or support that liver function.
And kidney function tests as well. So we're often looking at creatinine, urea, and estimated glomerular filtration rate, which like EGFR, which I just mentioned, is often the main one people will be looking at. Technically, on most blood tests, that's actually just done with a formula based on creatinine. So it's like the creatinine one is the one you're looking at the most there. I have two things I want to add on to both the kidney function and liver function tests. In that if you train hard, and I feel like a lot of people who listen to this podcast probably do train hard, if you get a blood test not long after training hard, as in within a few days, there are decent odds that some of your liver functions will be elevated. And same thing for creatinine as well. People with more muscle mass, sometimes that's elevated. People who've done a hard training session, sometimes elevated. Creatine breaks down to creatinine in the blood. So it's a byproduct of that, So therefore, that can be elevated. And those things can be false markers where it's like, well, obviously training hard is fine. Like that's not detrimental to your health. And if we do look at the research being like, is training hard causing issues with this stuff over time? It's totally fine, but it can be misleading on a blood test. So food for thought, if you really, really, really wanted an accurate blood test, the gold standard is to at least do a deload week, if not like take an entire week off training. There's a study I often point to, I don't think I put it in the show notes, but there's a study I point to where they got people to do one hard training session with weights if they were non-lifters but general active people, and their liver function tests were still elevated a week later. Crazy, isn't it? In my clients, I often only really see this more amongst like the psychopaths, like the ones who are just like absolute monsters with their training, who train really, really, really hard. But it is worth noting because I've seen a lot of people kind of freak out after a blood test, and it's literally just that they trained within a few days before going to get it.
That's such an interesting point. I actually wasn't fully aware of that. There you go. The last one I'm going to add into there is CRP, or C-reactive protein, which is a marker of systemic inflammation, can be elevated if there's chronic disease present, as well as potentially poor recovery for the body generally. It's one that we see, it can vary from normally quite low to being extremely high if there is an acute illness, and then also kind of lower or in between if there is more of that chronic disease.
It's also a common one I see amongst the evidence-based community where, say I see somebody post on Instagram that they're inflamed, there is often the response like, how have you measured that? Like, have you got like CRP elevated? Like, have you measured that? And it is just an interesting one to think about being like, when somebody says they're inflamed, sometimes it is inflammation. Sometimes it's pain, like they have joint pain. It's like, is that inflammation or is that joint pain? Sometimes there's swelling, sometimes there's bloating, sometimes there's whatever. But yeah, there are legitimate like blood measures of inflammation as well that we can look at. Now we're going to talk about hormones. So there's a few things. Where do we want to start with hormones?
Should we start with thyroid?
Yeah.
Yeah? Happy with that? So yeah, looking at things like TSH, free T4 and free T3 gives you a pretty good indication of overall thyroid function, which is important for your metabolism, energy, and then also that weight regulation. So knowing what those levels are to support that. Yeah.
Yeah, and that gets into probably the first condition that we'll be talking about, which is either hypothyroidism or hyperthyroidism. So hyper is obviously like elevated or a faster thyroid, and like hypo is obviously it's like downregulated, right? And as you mentioned with like energy, metabolism and stuff like that, the body doesn't burn calories for no reason. It's always linked to certain functions. If certain functions are burning through more calories, they're usually doing more as well. So if we go with hypothyroidism and we've got this like down regulation that we're talking about, you would see some of these markers out of range as well, but then that will often lead to certain symptoms. And then those symptoms will lead to a change in energy expenditure as well. For example, if somebody say their gut slows down, the body is spending less calories on digestion, so less calorie burn there, but they might get symptoms of constipation. Say somebody's core body temperature is like decreased a bit, or they're like colder all the time. Their metabolism is spending less calories on heating the body up. There's less calories that get burned there. This also then becomes interesting when looking at it. Say I was working with somebody with Hashimoto's or hypothyroidism, and we were concerned about whether their metabolic rate was lowered due to this. The research is quite consistent that if people's thyroid hormones are back in range, let's say with medication, their metabolic rate is quite similar to what you'd expect without the Hashimoto's or hypothyroidism as well. But the thing is that makes it tricky is if you're on medication, often that dosage needs to keep getting adjusted over time, and it might go too high, too low, or whatever. So there can be times that you get a blood test to see where it's at. Your hormones are still a little bit suppressed, and you may or may not need more medication to get back into range.
Should we chat about sex hormones then?
Yeah.
Yeah. So if we're looking at female hormones, we know that things like progesterone, estrogen, FSH and LH play a whole role in the menstrual cycle. So if we can definitely look at these numbers and have a look at estradiol, which tracks that estrogen status, relevant for your cycle regulation if you're going through menopause, that sort of thing, as well as potentially giving an indication of bone health. Same with progesterone. It tells us what sort of cycle phase we're at, and low levels can often contribute to that higher PMS, anxiety, or poor sleep.
One of the good things on blood tests is they often have reference ranges. And for a lot of these things, it's quite simple. Obviously, for women's hormones, it's way more complicated, and they have to kind of split up into the different phases of the different cycles. But on the blood test, often they do have these ranges. So say your estrogen was high for one phase, but you were actually in a different phase of the cycle. It could be completely within range there. And I think that's kind of relevant because these hormones are always bouncing around. So at least it's good to have ranges. And then if it was outside of those ranges for all phases of the cycle, for example, then that's much greater reason for concern and potentially taking action on some stuff too.
Yeah. Is that something that you ever ask your clients, what phase of cycle they're in if you're looking at these hormones?
Yeah, often it's noted down. Often they will be, yeah. Let's talk testosterone now. So this is another one that can bounce around a fair bit as well, but there is certain ranges that we would want it to be within. We obviously have free testosterone and total testosterone. And in terms of when I would consider getting this for certain people, say a woman has PCOS, we might be, or if they're looking to see if they have PCOS, we might be looking to see if they have elevated testosterone because that's one of the things in the diagnostic criteria. The other thing is in men, I'm not naturally going to go out of my way and get just everyone who comes to see me to go and get their testosterone checked. But if somebody is suspecting issues, and often is in the first consult, they're talking about symptoms that are linked with having low testosterone, it might be worth getting that checked. And then we have the options of, do we do some things from a nutritional perspective to try and address that? Or do we look at, for example, hormone replacement therapy, if that's something that would be suitable or what they're interested in as well?
Any that you wanted to add onto that?
I don't think so. I think that's covering most, yeah.
Amazing. Well, this has been episode 230 of the Ideal Nutrition Podcast. We hope we've been able to give you some insight into the blood tests that we recommend. If you enjoyed this episode, please leave us a positive review and we'll be back next week.